Hi, my name is Simon Parson, and I'm the Professor of Anatomy at the University of Aberdeen. And I'm speaking to you today about a condition that you may not be very familiar with, and this is called spinal muscular atrophy. And you might ask, why am I doing that for MND Scotland? Well, I hope I'm going to show you that spinal muscular atrophy is actually a type of a motor neuron disease, but perhaps one that you've not heard very much about. And the main reason I want to talk today is to tell you that we've had some remarkable successes in being able to produce and develop and distribute therapies for this condition. And things have really changed over a period of maybe sort of 10 years. And I think it's interesting to see that, there really can be hope in some of these diseases, and we really can learn fantastic things from research. So, and something which I've already alluded to, is that I've just told you spinal muscular atrophy is a motor neuron disease. And I have a little slide here saying, I think we should always try and bear in mind that motor neuron disease is a description of an end stage of a set of diseases which can have been caused by very many different things. And I think this is really important, because if we think that MND is one thing, then we're trying to develop a single therapy, a single treatment, or a single cure. I think if we understand that MNDs is a quite a wide range of conditions that result in certain pathology in those patients, we realize that some of the therapies we'll produce will only be useful for some patients. And I think that's particularly relevant at the moment when we think of the work about tofersen, which is, a great drug for treating just a certain type of MND that's caused by a certain mutation, which is SOD1. And I think when that drug first came out, it's easy to think that perhaps everybody was going to be helped by it. But actually, it's only a minority. It is fantastic for them, but it isn't for everybody. So I think this small S I've drawn in red, I think, is a really important one. That's not MND large S for Scotland, it's MND small s for motor neuron diseases. So I think that's just quite important when we're understanding how we can produce the therapies and help all those people affected by these conditions. So to go on a bit more with SMA, and here's a picture of a little girl actually with one of the more mild cases of SMA. So it is a motor neuron disease. It's one we've known about for a long time. So it was first described in the late part of the 19th century, when it's called spinal or progressive muscle atrophy. And I think that describes exactly what it is. It means those individuals would lose strength in the skeletal muscle, and those are the muscles that produce every movement that we do. They're allowing me to speak now, are those muscles. They're allowing me to sit straight in my chair. They allowed me to walk here to give my presentation today. And that can be linked back, as I think you will often know, that we lose these specific neurons, these nerve cells, which are found in the spinal cord. And the spinal cord is that structure that runs down our vertebrae, and from which nerves leave, and they supply those skeletal muscles which produce all those movements we just talked about. So if we lose those neurons, they're called lower motor neurons or alpha motor neurons, or sometimes ventral horn motor neurons, we lose that ability to connect our thought of making a movement with actually being able to make that movement. So, we think about a movement in our brain, but we carry out the movement because these nerve cells connect us to the muscle, which allows us to move our joints, to move our bones, and to actually make a movement. So we have a motor neuron disease here, which we know is related to a loss of these, what are called lower motor neurons in the spinal cord. Now, what's unusual for SMA is that it predominantly affects children, and it predominantly affects very young children. And you see at my final line here is quite a scary thought, that most of these children would present with a failure to develop their normal motor milestones, things like head control, rolling, prior to 6 months of age. And at that point, prior to therapy, the prognosis for those children was to survive for less than 2 or 3 years subsequent to that point. So this is an MND where for most affected children, their lifespan will be in single figures, which I think is, pretty dramatic. The little girl on the left has one of the more mild forms, and that's why she looks quite well, but although you can see she is in a wheelchair because she is unable to walk because of her condition. So let's think a bit more about what causes SMA, and this is really why we've been able to drive forward much more quickly with developing a therapy, because we know that in the vast majority of cases, so more than 95% of people with SMA have a single mutation in a single gene. Now, we know a bit about how that's inherited. It's called an autosomal recessive. That means it's not particularly linked to being male or female. It means that if you're a carrier, you will probably almost certainly have no pathology that we can see. How many people are carriers? Well, the answer is about 1 in 55. That's quite a high rate. And what our little picture shows here, that if 2 carriers come together to have children, they'll have no knowledge they're carriers, but there'll be a 1 in 4 chance every time they have a child that child will be affected by SMA. That's the green, that's the purple child. There'll be a 1 in 4 chance that child will be completely normal and won't be a carrier. And there'll be a 2 in 4 or a 1 in 2 chance that those children will be carriers and could go on to have an SMA affected child at the next generation. So we know it's inherited, and unlike how I started, it's a single gene. So we can target a single gene potentially when we want to design a therapy. We don't have to think of numerous reasons why these individuals have SMA, because they all have SMA for the same reason. And just to sort of note here, an important thing for us in the field is to understand newborn screening, because we'll see a little bit later, the sooner we can treat these children, the better their outcome will be. Newborn screening is available throughout all of America and through the vast majority of Europe, but it isn't available in the UK. It's supposed to be starting in Ireland before the end of the year, but it hasn't happened yet. But in Northern Ireland, the rest of the UK, it still isn't available. It's something that we're pushing for, but hasn't happened yet. So we go a little bit further on now and say, we know it's inherited, but what do we know about what is being inherited, and why does that cause us to have a motor neuron disease? Well, excuse me if this slide looks a bit sort of technical, but it's important that we think a little bit about this because it's helped us how we understand how to treat the disease. So SMA is caused by a mutation, which I described, and it's in a mutation of a gene which produces a protein, and that protein is called SMN. Now, it was named as survival motor neuron, SMN. Every animal species has SMN, and SMN protein is really important just for the normal functioning of all cells. If you have no SMN protein, your cells will not be viable. So you won't survive past very early developmental stages as an embryo. So how can we have a disease if we have damage to a gene? Well, the human population are unusual in whole of the animal world in that we have a second copy of this gene. So that's why in our picture now we have one gene called SMN1 and one gene called SMN2. So in the normal state, you'll see here that SMN1 produces lots of normal protein. That's all those nice gray circles on the left. SMN2 has got something wrong with it, and it only produces some normal protein. So you'll see that nearly all, instead of having nice gray circles, we've got little blue kind of Pac-Men with red crosses through them. So it means that gene is producing quite a lot of protein, which we'd call junk, and a small amount of protein, which is okay. So what happens in the disease is we lose all the protein from SMN1. Now, in any other animal, that would be fatal. But in humans, we have this second gene. The second gene is not very good, and it produces some protein, but not much. But that some protein is enough to make us viable, but it's not enough to make us healthy in the long term. So what I'm saying at the bottom here is that SMA is a disease of low protein, not no protein. Because if you have no SMN, you will not be viable and you would never be born. But because we have SMN2, that's coming from SMN2, we have just enough protein to be viable. And actually, this SMN2 gene is what regulates whether we have a severe form of the disease or a mild form of the disease, because we can have multiple copies of SMN2 gene. So this is really important. If you have low numbers of copies, you'll have a severe SMA. If you have higher copies, you'll have a milder SMA. And the little girl in the previous slide had more SMN2, therefore she had a slightly milder version of SMA. So we have a disease that we understand quite well. We have a gene that produces a protein. The protein is really important for life, and we need to have just enough of it. I always stop here to show you what the state was really when I started working in SMA. So I've been working in SMA for about 15 years, maybe slightly more now. And early on in my career in this particular piece of work, I met the parents of this young lady called Estella. Her name means star because her mother was Spanish, and it's a Spanish word. And she's got her little Superman baby grow on here. And there's just 2 dates there, and you might be able to guess. And this poor little girl was diagnosed at 8 weeks old, and she only survived until she was 8 months old. And, you know, that was, you know, it's always been an important thing that I go back to thinking about the disease, because there was nothing at all we could do for that little girl and her family other than to say, we know you have a severe type of SMA and we can't do anything for you. And, you know, that had been the situation, obviously, for a great many years since 1870. So, you know, this is over 100 years later, we'd learned something about the disease, but we still couldn't do anything. But what I'm here to tell you is that things have got much, much better. I think it's quite nice to have quite a serious note of optimism after this. But I always include this slide in all my talks, really, just to make people stop and think of really how far we've come and how awful this condition was. So how have we been able to advance? Well, I've already been giving you a few kind of hints here in that we always knew it was inherited. But it took until 1995, so that was another 100 years before we actually found the gene. So we identified that SMN gene in 1995. We identified that was the most common cause of SMA by far. I say more than 95%. We learned that the level of SMN was the key thing. And we also knew we had this second backup gene. And for the really advanced part, some clever geneticists found a very specific part of the genome which we thought we could use to understand how to make that gene more active. So even though we didn't really know what the SMN gene did, we didn't know what the SMN protein did, we pretty much could figure that if we could increase the amount of protein in cells and in patients, it should target the disease and it should make things better. And that was the drive early on. And to be honest, actually, we still don't really know why the SMN gene is important, but we do know if we put it back, and if we put the protein back, those both animal models and the patients will survive for longer and will have a healthier life. So here's the kind of good news in that we now have 3 therapies which have all been approved for treating children. And we have one called nusinersen, which is a thing called an antisense oligonucleotide. We have one called Zolgensma, which is a very advanced form of gene therapy. And we have one called risdiplam, which is a small molecule which can work in a similar way to nusinersen. But what they all do is they allow us to produce more protein. So we've got 3 therapies, and I'm going to tell you a little bit more about what kind of time period these came online and how they developed, and just a little bit about how they work, but not going into sort of too much of that detail, I hope. So first to say, look at the range of ongoing trials at the moment. And I think this is something that's really been surprising to me, because when the first therapy came through, it really accelerated other trials in the area. And I think this is because pharma are always nervous of working on a rare disease or something that seems incurable, because they can spend millions and millions of pounds or dollars and not get anywhere. I think once you have an initial therapy, to some extent it de-risks the whole area, because you've proved something can be done, and that really opens up kind of research in other areas. And I've been really surprised in SMA that from that first therapy, actually the amount of other work from pharma has increased enormously over that time. So I think that's a really nice thing to understand as well, that once research starts to be positive, it really can accelerate things. I never know quite why all the trials of risdiplam were all named by a fish, but it's one of those things. So what we're saying here, as I've showed you before, we can either have a therapy called an antisense, one called a small molecule, or one called a gene delivery or a gene therapy. A look at those. So here's the first one. So this first one was made by a firm called Biogen, and there are 2 approaches here. So I've told you that in SMA, we lose the function of SMN1. We still have SMN2, but SMN2 isn't very good. So what this first therapy said was, can we improve SMN2? Can we make it make more healthy protein? Because more healthy protein will make more healthy cells, will make a more healthy individual. And this is a thing called an antisense, and it worked in a kind of double negative way, because there is something in the gene which is making it worse, if you like. The antisense stops the thing that's making it worse, and then the double negative makes a positive. So it's an inhibition of an inhibitor, if I can call it that. What the important things was, this was first approved in 2016 by the FDA in America. It was and then it was then approved by the European Medicinals Association, and it is now approved for treating 3 types of SMA in the UK: type 1, 2, and 3, where type 1 is the most severe. What's challenging about it is the bottom line here. It says delivered intrathecally, and it has to be delivered into the fluid surrounding the spinal cord. So it's quite a challenging injection in between the vertebrae into the spinal cord. It's a bit like having an epidural, but these children have to have it 3 times a year for the rest of their life. It's quite challenging. Very many of these children have scoliosis of the spine, which is a curve and a twist, and that can actually make this even harder to do. So it's quite a challenge. The children have to travel often quite a long way to a centre to have what can often be quite a long, uncomfortable and painful treatment, but it significantly enhances both their quality of life and their lifespan. I can't tell you what their lifespan will be, because we only started to treat children in the trials in maybe 2013. So the oldest children are still mainly under the age of 10. So at the moment, a lot of these children are surviving, are doing well. Not all of them, but hopefully, they will have a long life. The second drug to come along was at the time the most expensive therapy for any disease in the world. It was priced at, I think, as you see there, $2.5 million for a single dose. But the idea is you only need a single dose. So here's the opposite approach, and this is targeting that SMN1 gene, and it's saying, why don't we give you back a newly functional SMN1 gene? So this is a classic gene therapy. This was first approved in 2019, so just 3 years later. And the advantage here is it should be just at a single dose, which should last you for life. However, it's hugely expensive, which is a big deal for health services. And also it has to be delivered very early to the children, because there's only a certain size of dose can be given, and that is dependent on the weight of the individual. So this is a therapy that we really need screening for, to identify children very early, to be able to give them a therapy before they're too large for us to be able to treat them. So we really have to target these children in the first few months of life. So really interesting therapy, but as ever, has some issues. We have a third therapy, and this is, I think, really an interesting one. So this came through just another year later, 2020. And what's really interesting here is this is an oral drug which you can take every morning for the rest of your life. So first of all, you don't have to come to the clinic. You don't have to have an invasive procedure. You can just take a small liquid dose every morning. And I think you will know quite a lot of the drugs we're hoping to develop for other MNDs. We like to focus on something that will be orally available and can be orally dosed. So this is a really interesting one to tell us how we might be able to go forward. And all of these now can be used in Scotland. They're not on an approved route. They're on a specific ask for the patient, ask the supplier, and work out how that works, because they're all, in the long run, extremely expensive, but very powerful. But they would really benefit from that newborn screening. So, we've done fantastically well. I can now say to all sort of groups, if we can diagnose you as early as possible, we can put you on a therapy, and that will stabilize any loss of motor neurons and allow you to gain function that you would not normally have been able to gain. So interesting here, in children, they fail to gain the ability to do things, rather in adults, we are more used to they lose the ability to do things they could do previously. So it's just a bit of a different way of thinking about things. So is the screening the answer? Well, yes and no. This is just a tiny piece of work that I've been doing with my group here to really describe the condition carefully. And we've been amazed to see really the rate at which these motor neurons can be lost. So some of these children, even at birth, have already lost possibly hundreds of thousands of motor neurons. So if we treat them even at birth, there is probably a ceiling on what their function will ever be, because you can't replace lost motor neurons. So if you've lost very many of them, even if you save all the remaining ones, they can only do as much as they can. If you have only 50 or 60% left, you'll never get back to full motor function. And the way we don't have a good way of assessing that. And also something that I'm not going to really go into, but it seems that SMN protein is important in all cells, and that there probably are defects in other systems, the cardiovascular system particularly, as well as organs like liver, kidney, and spleen. And we really don't know if any of the therapies we've designed are going to target those cells, because it's not what they were designed for. It may be something that will come along. So I think, we've always got to take everything. There's always need for more work. We've done fantastically well, but we've got to keep working to understand the disease. So is this relevant for other MNDs? Well, here's a figure that I have taken from one of the charities online, and just to show that there are similar therapies, similar therapeutic approaches being used. So you see those antisense and tofersen that I mentioned for treating SOD1 is an example of an antisense oligonucleotide, the same as nusinersen was. There are another couple of antisenses which are targeting both C9orf and FUS forms of MND. So certainly antisense technology is being looked at in the MND area. And also AAV9. So this is an example of a virally delivered gene therapy, and that would be similar to Zolgensma in the way it was designed. What it will be delivering will be different, but it's a similar methodological, pharmacological approach. So, that work that has come forward in SMA has been a really good proof of principle that these things can work in the nervous system to either rescue motor neurons or in some other way improve outcomes and ameliorate the disease. So they certainly are sort of moving forward, but MNDs are much more challenging because of their varying reasons that we think are causing them, and for some of them that we don't understand even how they're caused. So just very quickly, what do I do? Well, I work on SMA, but I'm really interested in how it affects other cells that aren't motor neurons. And I'm particularly interested in blood vessels. And our work is really looking to say is, are blood vessels in the central nervous system, are they triggering the disease? Are they making things worse? Or will they continue to make it challenging even after we've rescued motor neurons? And that's a really key focus of my work, and understanding, might any of the current therapies be treating blood vessels? If they're not, should we be? So I think there's always ongoing work. I always say, you know, I hope the treated children will have a long and healthy lifespan. I'm far too old to be able to see that. You know, I might be able to watch those experiments for another 25 years, but we're hoping those children have got a lifespan of another 70 or 80 years. So this is a really long-term experiment. I'd just like to thank all the people that I've worked with and some of my key collaborators here who I've published work with in the past. And I think the only interesting thing here to see is that they're all over the world. And, you know, the work I do and very many of us do is only possible because of our collaborations, both in the UK and in the much wider and far afield in the whole of the world, because we take expert groups in all those areas and manage to work together. And I think as well, just to saying that I couldn't do a lot of my work if it wasn't for the fantastic donations of families after their children have died to allow us to take post-mortem tissue from them, because sometimes that's the only way we've been able to find out the core processes happening in patients. So, you know, I'm fantastically grateful for the families in this case who have chosen to give that you know, unbelievably hard choice of saying, yes, you know, my child will be available for a post-mortem to help with research in the future. You know, a really tough choice, but actually fantastically important for work in the field. So just I say, thank you for listening today. I hope I've taught you about one type of MND that you might not have heard of, and also that, you know, we have moved forward fantastically, and hopefully some of that will be translatable into other forms of motor neuron diseases with the small s on the end. So thank you very much for listening today.